I'd like to welcome everybody to Pediatric Grand Rounds. I'd like to begin with a land acknowledgement. We would like to acknowledge the Ramaytu Shaloni people who are the traditional custodians of this land. We pay our respect to the Ramaytu Shaloni elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytu Shaloni community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I'd like to call up our Vice Chair for Education, Dr. Sandrain Van Schaik, to introduce our speaker today.
Good afternoon and welcome, everybody. It's really a pleasure to introduce our speaker today. And it's a special pleasure because it's really indicative of how we plan our Grand Rounds series with a planning committee that is quite diverse in its composition. It's not only physician and it's not only faculty, but it's physicians and nurse practitioners and chief residents, and all of them have different interests. And so we always come together twice a year and start shouting out names and topics that we think are interesting, etc. And as a result, we have a much broader horizon of people than I personally would be able to come up with. So our current speaker for today, I have actually never met and just met today, and it's a pleasure to meet her. But she is here to talk about a topic that is incredibly important to the pediatric community. And I think we have Dr. Meg McNamara to thank, who's a member of our planning committee and the Pediatric Residency Program Director for this invitation. So our speaker is Dr. Anne Glowinski. She joined UCSF in August 2021, and she's the Robert Porter Professor and Division Director of Child and Adolescent Psychiatry and Behavioral Sciences at Mission Bay. And since July 2023, she's also the Interim Director of the Infant, Child and Adolescent Psychiatry Division at GSFGH. And until taking that newest role, was also the Division Director at our Oakland campus. She's the medical director of the UCSF UCB Schwab Dyslexia and Cognitive Diversity Center and of a new collaborative care clinic. Before joining UCSF, Dr. Glowinski was the training director for 17 years and an associate director for the Child and Adolescent Psychiatry Division for 11 years at Washington University School of Medicine. Dr. Glowinski is recognized nationally and internationally as an outstanding clinician, an education expert, and a versatile clinician scientist who has led or contributed to many projects related to community mental health for children with a dual focus: to either elucidate preventable aspects of past to common and or impairing psychiatric disorders or symptoms with usual childhood onset or the precursors, or reduce the public health burden of those disorders or symptoms and improve the experience and care of their patients and their families through collaborations with other pediatric specialties or agencies. She has published over 70 peer-reviewed manuscripts and has received notably awards in education and science. And as I mentioned in the beginning, she has very many leadership roles here at UCSF. So we're incredibly honored and pleased that she was willing to take out some time out of her busy schedule to come and talk to us about pediatric mental wellness. Dr. Glowinski.
Thank you so much for having invited me, whoever it was that suggested my name. I will acknowledge a couple things. One of them is that I'm very familiar with academic grand rounds and how you yourselves are pulled for attention in many directions and how hard it can be to find time from your busy schedules. And for the people who are on Zoom, I know that you're also probably having a lot of competition for your attention, and I hope that you can spare some for this talk. This is not a usual talk for me for many reasons. One of them is that there are things that have not happened because of the pandemic in my career. One of them is that if I had thought about how much I would have already created connections and integration with pediatrics 2 years in a division chief position, I think before the pandemic, I would have anticipated a very different landscape where it would be easier to get together and have conversations. So this is overdue. This is an overdue conversation. Secondly, it's not usual because I think that I need to recognize that in the absence of this full integration and read of the landscape, I'm coming in with the risk of telling you things you already know, telling you things you're already working on, and thus being very, very rude, right? Like when you come in and you're like, oh my God, these furnitures, you have to change them. So it is really not my intention to do that. It is not my intention to omit pieces that you've all worked hard on. I am fallible. I recognize that the deck of cards I've had is not usual. So please take that into account. The other thing is that, like a lot of us, I'm battling sort of digesting world events that are very distracting and impacting a lot of us currently, and personal issues that I won't deconstruct at this point. But so I have notes. It is absolutely my standard to speak without notes. And I will tell you that if I did that today, I would probably be missing a lot of pieces. So I apologize for that. It is my intention to connect with you nevertheless. So sort of taking a step back, what is this talk? It's trying to not be a typical academic talk, because the typical academic talk is, hello, I am an incredible expert. Nice to meet you. I am going to present data in a way that is a little bit divorced of emotions. And you will zone out while I'm presenting data because it's hard to follow data that you haven't put together yourself. It's hard to maintain attention to sort of cognitive things that are devoid of emotion. So I am trying to add emotion to this talk. Again, like whether I land the right amount, the wrong amount, whether every nervous system in the room or on Zoom finds that appealing, I don't know. I don't have control of that, but I can deconstruct that it's my intention to be engaging so that we also can sit with the emotion of what's going on with child mental health, because that's really the key message here. So the first thing that you probably know already very well is that the COVID pandemic, which has highlighted a number of things, including the disparities that we've essentially have lived with in our society for a very long time, has exacerbated an epidemic of child mental health issues that really has existed pre-COVID. So to kind of orient you, we're now saying that too many young people struggle with their mental health, are unable to get the help they need. So that's our Surgeon General in one of his latest release. But the reality is that before COVID, pre-COVID, here is what the barometer showed in terms of prevalences. So first of all, between 2016 and 2019, the unmet need was already severe. So we already had between the ages of 3 to 17, a prevalence of impairing ADHD that was 9.8%, anxiety 9.5%, behavioral problems about 9%, depression 4.5%. And as you can imagine, this is not this talk today, but there is a wide range of consequences, and I'll briefly allude to that, but there's a wide range of consequences of not addressing these issues. Horrifyingly, and maybe to sort of anchor how important it is to meet these needs, suicide remains the second cause of death in youth, including in California. And we're going to get into that a little bit. What I also need to highlight is that the current conditions of care are really ineffective. So most youth who need it receive zero mental health services. So we're not even talking about high quality. We're talking about anything at all. So 57% of kids who need something get nothing. And then what, if you had to make a guess of how many kids who actually need treatment receive evidence-based treatment? What would be that guess? You're smiling. Don't worry. It's just make a guess. 2%. 2%. So I want you to remember that data, because I think that we are here today because everybody agrees that the solution to that really has to come from a multidisciplinary process. And in particular, because of your roles as pediatricians, your interactions with children and family, the role that you have in anticipatory guidance for a number of things. I'm a mom of 3. I remember being blown away and really impressed by my pediatrician, who, in a sense, was reading off a lot of risk factors that she wanted me to avoid, essentially transmitted to my kid. So she was going over, are you putting a seatbelt? Are you feeding them? Are you doing this or that? So what we're talking about is that you do all that, but mental health is separate, and we're going to come back to that. So to just get us a little bit more warmed up, what is known about the impact of poorly addressed child mental health. And this is a simplification. And obviously we have people who have both physical and mental symptoms. Actually, this hospital is full of them. Your clinics are full of them. But we know that from epidemiological studies, when you look at the signal of having a significant child mental health problem, in terms of impairment and outcomes, it's actually worse on average than a chronic physical condition. Of course, there are chronic physical conditions that are more severe. So this is an average. And we also know that the younger the onset, the more time it takes to actually receive any services. And we also know, you can see that quote, that the availability of good care is really inverse to the need. So what do we know? For example, we know that during the COVID pandemic, which had very wide-ranging impacts on educational conditions, caretaker employment, teachers, other key adults who really are important for the mental health of children, a lot of determinants of health were hit, and that they were hit disproportionately, depending on what ethnicity or socioeconomic background you had. So for example, here is a number that is really important for us to digest. Black children disproportionately experience the loss of a caretaker, which is really a cornerstone of development, having a caretaker. So 1 in 310 Black children versus 1 in 738 white children. So you can see how right away the decks are loaded very differently depending on what background you have. So the other thing is that there has been a lot in the space that is collaborative. And it hasn't worked that great yet, as far as we know, in children compared to collaborative care models in adults. So what I will say, as somebody with an epidemiological background, is that first of all, that happens when the web of causation for the outcome is really complex. So the issue of access to good care is a really complex web of causation leading to that. So I will walk you through some of this. And so any solutions to really work ideally is either hitting many of these risk factors in a way that is concerted to move the needle, or is working with other projects that are tackling different parts of the web of causation, but checking in together and working collaboratively too. And so that's something that we don't have in place at all in the United States. We have pieces of it in California that I'm going to talk about. We certainly don't have it yet at UCSF. So if you're a child, essentially, you're at the mercy, first of all, of a system. So if you look at the left for societal factors, this is very simplistic. There are a lot of things that are missing, right, from this, but to create a heuristic representation. So first of all, stigma has impacted the very fabric of our medical systems themselves and how separate we are in mental health in terms of insurance or service organization. There's a lack of system design. Like if you're just looking at what kind of product are we producing, and there's a lot of lack of regulation too in terms of what consists of a therapist in the community or somebody who's providing mental health services. It is very confusing for you, I imagine, for patients, and even for us. And then the part that you are supposed to play a role is almost a source of indignation, I know, for some of the people in the community. At least it's been during my career. I have worked with pediatricians for a very long time. And there is often initially almost a like, why don't you guys take care of this? Like, this is your specialty. And so one of the things that you need to understand is that because our specialization designs have not kept up with the epidemiology, have not kept up with the numbers that I told you, my specialty is considered a subspecialty. So that has implications in terms of funding. For any of you who are training directors of a fellowship, you know how it's hard, right, to get funding for a fellowship. So we're fellowships. We don't get a lot of money to train people. We have a huge deficit in terms of number of people. Also, my specialty, because it hasn't linked to epidemiology, sort of sits between a rock and a hard place. I think that's an English expression, between pediatrics and psychiatry, being marginalized in a sense in both. So the bridges to psychiatry when I was training was, this was definitely considered almost like an absurd specialty. Like a lot of the models where children don't have psychiatric problems. This was even after there was epidemiological evidence, but essentially the academia in psychiatry was not considering this seriously. So we're talking about the 90s now. And it was almost a space where a lot of cliches like, well, if parents knew how to raise their children, there wouldn't be any problems with children. Like it was ripe with this kind of things. And then in pediatrics, I think that what I realized is that even after I joined the ACGME, which I literally did not because I felt like I had tons of time to volunteer on tedious processes and reviewing programs from all over the country, but I wanted to see if we could change the curriculum in psychiatry to reflect the need for psychiatrists to be more trained in child psychiatry, because that's a need. And I also wanted to see what we could do about training people more deliberately in collaborative care, which is really somewhere that society needed to move. And do you think that was easy to do that? No. I spent 10 years on the ACGME. I was a broken record. Everybody agreed that these were important things, but the bottom line is that it took an epidemic, it took COVID to really sort of elevate and push this. So at the level of our interface, what we don't have is a roadmap where we even have agreed, and I'm going to come back to that, on like how we triage the mental health issues of our young. So if you look at my diagram, you will see that on your end, this is again like a gross generalization, but there are issues about specificity and sensitivity for what you refer. There are issues of practice on my end that really are formidable in terms of like how child psychiatrists were trained to see patients which didn't take into account the situation that we have in. We have a lot of silos, we have a lot of lack of resources, and essentially it all combines to not necessarily spending the time that we need to really talk about, we have a dire situation, how do we put things together? How do we create a system that we iteratively test to see if it can move the needle forward? So we're going to talk about that today. I am going to pull out some of the things that I have comments about that are reasons for optimism. And so the first that I'm going to start with is stigma, which you can see at the very top to the left. And the reason I want to talk about stigma is because it is a bit of a mess in medicine, and it is something that we can all do something about, and we should. So here is an image that you see, and you can see my title, that stigma is continually and insidiously distorting the perceived seriousness of the situation. So in this room, many of you have had depression, or on Zoom, many of you have had anxiety. Some of you have ADHD, whether it's diagnosed or not. Some of you may have more severe psychiatric disorders. What the data suggests is that most of you have not talked about this with your friends, with your colleagues, and that when we talk about it, there are hierarchies of stigma. So for example, it may be more acceptable to say, hey, I have anxiety, I'm in therapy, but to say something like, I'm on an SNRI, or I'm on a SNRI augmented by an antipsychotic, for my depression is very stigmatized. And that's shown in the general population and in our fields and in psychiatry as well. But this image that you see is a famous fashion brand in France. I'm French. And so it's called, to translate, Rich Depressed Children. Why did I pick that? Because I want you to sit with this idea that we live in a world where it's acceptable to have a brand that, in a sense, suggests that depression is a luxury. And imagine what this would be if we had a brand, a fashion brand that was called Rich Children with Cancer. You would be horrified, right? This is not creating the same kind of reaction, because mental health is in a black box of its own that we have a difficult relationship with. And so as clinicians, it is really imperative that we deal with that. And I can tell you, having treated a lot of children who are the children of doctors and nurses and other clinicians, this comes up every time. Like, I will have the most compassionate person who is an ICU nurse, for example. This is completely de-identified and over a career of decades. And that person will have to wrestle with the fact that their empathy and compassion and patience with the symptoms of their child is completely different than if their kid had cancer or was in dire straits because of something else. So we have a very different relationship with mental health issues. So what can we do together? I mean, I think we need to, first of all, take stock of what's happening in our professions. Women, this has not been updated for COVID. And so we suspect, given the toll on women, that this may actually be getting worse, given the intersection of doctorhood or clinicalhood and the combination of gratitude, but also no resources necessarily to help us do our jobs. That has hit us really, really hard. And so in general, female physicians are at an elevated risk for suicide. And it's in part because we know how to do it. That's really the reason. We know how to do it, and we also don't get help for it. So this is not because we're horrible patients in general. So we're actually pretty good if we have a different health issue compared to the general population at getting help. And so it really has to do with the stigma of getting help, naming it, getting support, getting treatment. So again, the reason I'm bringing this here is because it is impacting whether we engage in collaborative care or not, because we each have to have a reflection about dichotomizing physical and mental health and having these reflexes. I have them too. I push through my mental issues. Like right now I have a dying cat at home. I am pushing through. This is the norm. It's not the norm to talk about it, but I'm trying to change how we do things, right? A little bit. If I had like a broken leg, I would probably react to that very differently, right? So we have very different reactions, and we need to think about that, and we need to examine the toll of that. And then we need to be mindful of what we're modeling to our trainees, our colleagues, our patients. And then the other thing is, I don't know how many of you in the field of education are familiar with the concept of intraprofessionalism, but it's that idea that part of what we expect clinicians to do is have a responsibility to themselves in the name of the care that we provide, right? So that we don't put in the space, technically, those issues that we have. That's a very tall order. We haven't worked that out well. And we certainly don't do it similarly for mental and physical health, because with physical health, it would be like, oh, so-and-so is in the hospital taking care of this and that. And we don't even worry about HIPAA. But if it's a mental health crisis, we would talk about it obviously very differently. So we have to examine our discomfort and reckon with the fact that really there's no health without mental health, and we participate in the problem by not examining the internalized stigma that we have. And I take responsibility for that too. I'm not putting that on you. One of the biggest humiliation of my career, which was very salutary, was realizing that my field was also struggling with that. And in a way, we have more responsibility to take care of that. So stigma aside, the toll of mental health issues is enormous. So this is from the Global Burden of Disease Survey, which is freely accessible. You guys can go and you can play with it and get information about what's happening in the world, what's happening in the state. You can't really get a multivariate resolution, you know, and there's also issues if you're a pediatrician, the biggest issue being that if you will, the age classes do not correspond well to things that we care about. So for example, for psychiatry, the age class of before 5 and then, or before 4, and then 5 and 14, and then 14 to 49 is not enormously useful in terms of resolution. But what you can see is that very early on, there is a high cost in terms of disability adjusted life years. And so for those of you who have not dealt with these concepts before, it's really a sort of combined variable that equals the sum of the years that you're losing because of a disease, and then the years that you're living with the disability. So if we are thinking about child and adolescent mental health, let me give you some numbers so that you get a sense. So first of all, in California, we're talking about California, 25% of essentially years lost to disability are due in the group that is between 5 and 14 already. 25% of that relates to mental health issues. And 20% of this variable that I just described, which is a combination of death and disability, if you will, relates to mental health issues. By age 14, it gets worse after. By age 14. And that, according to a recent paper actually in the Lancet, some of this data may have not completely taken into account the burden of mental health. And so they estimate that really the burden overall in the world for these dailies for the age groups that we're talking about of 5 to 14, it's close to 16% in the world. So more in higher income countries, but it's still very significant. So what about like the general pre-post-pandemic mortality rates for children? Again, agreeing that it's a very extreme measure. It's sort of the top measure, top of the iceberg, not talking about other forms of impairment, which I could give you a laundry list of, but dropping out of school, getting pregnant early, having relational issues that include violence. Like a lot of things are like dominoes related to mental health issues. And so what you can see is that it's hard looking at the mortality rates for children and adolescents in California to really necessarily be that concerned. But if you look at, and part of it is that it's a lot of data and a very big population, and there have been advances. I mean, I think we should be proud that between 1990 and 2021, the mortality rate for children has declined because of efforts in neonatal care and prevention and a lot of things that you guys have done relentlessly. But the piece about mental health is different. And this is why I'm here today. So what you're seeing is that, first of all, there was a signal, not necessarily for suicide. So this is actually what you're seeing is and these are freely available data, like vital statistics data for California, looking at accidental death, homicides, and suicides between 0 and 24, so dividing into categorical groups, non-overlapping categorical age groups, and sort of looking at what happened right before the pandemic, what happened in blue when the pandemic was starting, and then continued, and then in theory, where we are now. There's already data for 2023, but it's censored because we haven't finished the year. So I didn't include it. And so what you're seeing is that in terms of suicide, it's hard to see that there was a major impact. If you look closer, one of the things that happened is that there were kids between 5 and 9 who never commit suicide. That's just really, really rare. And so there were more of those that did during the pandemic, which from my perspective is a signal that things were really, really, really bad. Because again, like something that is developmentally not usually there was there. And then what you're also seeing is that accidental death have risen and continue to rise. And I'm not the first person to point out that accidental death are also going to overrepresent misclassified suicide, risk-taking, and a lot of behaviors that I know for a fact also relate to mental health issues. So there are things that we can observe related to the pandemic if we look at the mental health impact, but this is only the tip of the iceberg. So going back to this, I want to talk a little bit about the issue of relative absence of mental health training in pediatrics. I don't want to put all that emotion as I'm just meeting many of you, but this is something I've really been obsessed with for many, many years. Education is a passion. So I think about a lot of creative ways in which we can approach problems of education. And so in the systems that I've worked in, I have approached pediatric leadership for decades, sort of saying, if you want to experiment with educating your residents, I will do it. We can get together and do it. And sometimes I got really, really close, like it was going to become a mandatory rotation actually at WashU. But then the training director changed his mind. There are a lot of pressures. And so I want to acknowledge that part of the issue is that this is really disruptive for Meg and for others. I've been a training director before. A lot of the educational curriculum is a house of cards. There are all these people and these stakeholders, and to suddenly have a new rotation is difficult at UCSF. It's incredibly difficult in places that don't have child psychiatry or child development or adolescent development. But even at UCSF, it's difficult, even with somebody like me sort of saying, hey, can we work together on this? It's going to be difficult because it's disruptive. And so part of what I'm hoping we can ground on is that it's a necessary disruption. It's a necessary disruption because otherwise, again, the way that we practice, the way that we conceptualize health continues to perpetuate this disparity that is disproportionately impacting children that are already impacted by disparities. So again, I told you I would be emotional. I am emotional because I understand disruption. I'm a leader too. It's really a pain to balance the fires that you need to put out and innovation, right? But this is a necessary move. And I think a lot of us know that. And so what I want to do here today, like invited in your house and very aware of the privilege of that, is tell you that even if I sound forceful and I hope not arrogant, sometimes I do, but I'm not aware of it. I really am here to partner and talk about how we can do this together. And I have a lot of ideas. I have some experience, so part of the experience that I had was, how can we do this without a mental health rotation, and mentored people to look at educational approaches that were available at WSU. Like I used to be in charge of the patient-doctor communication, so I was very experienced with standardized patients scenarios and how to build them. And so we successfully built very brief interventions, not even a full rotation, that could move the needle on skills, could move the needles on confidence, and could move the needles on the needle on what happens when you see a patient next. I can tell you one of the proudest moments of my life was coming for a baseline follow-up for my 12-year-old, who was my baby. And my pediatrician, Dr. Cruiser, this extraordinary woman who really was uncomfortable with mental health previously, doing a PHQ-9 and like looking at the PHQ-9 with my kid and sort of, you know, being a completely abnormal parent, that I was really glad that we were asking my kid about suicide. But like that was a moment, you know, where we could see that you can educate people but you need to do it in a very deliberate way. So I've also been thinking a lot, and I want to learn more. And I'm going to talk about some of the setups that I think will allow us to learn more. I want to think about what is it to be a pediatrician who has to see these patients that ideally we package for you with a roadmap. And what is it like to have, I don't know, 15 minutes versus the 50 minutes that I may have. And I've been thinking a lot about that and thinking that there are actionable things that we can give that would be similar to the anticipatory guidance that you give about other things, you know. So I don't think it would take a very long time to explain, for example, the impact of anxiety in a family and how parental anxiety or other anxious elements are contaminating the child. So I've been thinking about what are things that we could, in a sense, inventorize that would be actionable and practical for pediatricians. And we're going to need to check with you to really talk about, for example, when you see this situation. So anxiety is a big buzzword. So you're seeing a situation of school refusal or another anxiety factor. And you can tell, right? Like how many of you can tell that the parents are somehow contributing, but you're not really sure to address it. But you know that they're having fights, and you know that the parents sometimes give up and they start doing things like not bringing the child to school, and you're like, the kid needs to go to school, and the parents are like, no, we can't. And so we really need to get into the weeds of like, what can you tell this parent? What can you do that I'm going to do maybe a little bit longer, but like, what can you do? And I think that is actually a low-hanging fruit that is within reach, because you can use this model where you essentially say, we're not blaming you for the anxiety at all. We're just identifying that you are sort of fueling into it. So like you're lighting a fire under it. And that legitimately, especially if you're asking us to help your child, let's see if you can also manage your anxiety, because that will immediately have an impact on the child. You know, so I'm thinking a lot about these kind of things that if we have a 1 month rotation, we need to give actionably to pediatric residents. Because one of the things I've learned from working with pediatricians, and you can see that in the slide about pediatrics, and I apologize for the oversimplification, but I remember the importance of algorithms. You know, I remember, so in my specialty, we don't walk around with little algorithms, which maybe we should, but I remember that the pediatric residents or the pediatricians were like, just put this in a little card for me so that I remember and learn how to do it in a practical way, given my schedule. So the other thing I want to acknowledge is that we have a lot of people with initiatives in the collaborative space at UCSF, and I'm probably missing a lot right here, but we have many programs. One of the ones that I really want to highlight today is our CAP portal. And the reason I want to highlight it is because the more we grapple with the size of the problem, the more it's very clear that if we keep doing triaging hand by hand, which is what's happening right now, hand by hand, without necessarily an algorithm, we're not learning to do things better. We're just doing things the same, and it's very frustrating. And so a system of triage where for now, we have maybe a preliminary sort of layer of exchange between a mental health provider and a pediatrician makes a lot of sense, whether it's through the CAP portal or through the e-consults that we're trying to tweak for the collaborative care clinic that has started this year. And I'll tell you a little bit about that later. But essentially, what the CAP portal provides, and I know from estimates that maybe 75% of the community pediatricians on the Zoom or are aware of this portal, but not all of them, is literally a service of on-call child psychiatrists currently who will hear about the problem that you have and will call in real time when you need it during the day. So you have to enroll in it. I'm not going to open the hyperlink, but it is a website with a lot of resources, including for parents and pediatricians. It is also a service that provides, going back to this issue of like, nobody has a roadmap, and so we're doing things hand by hand. It is set up to provide a navigation of resources service for people. So we have one person who is dedicated to updating, if you will, the inventory of resources and to be an expert at giving that information to the team and making sure that we're current on it when we interact with you. So the CAP portal is in the process of being funded at the state level so that we can actually cover pediatricians in California. It's a huge headache, as you can imagine, with a lot of stakeholders, some more reasonable than others, but we are really, really working hard to make that happen. And that is going to be, I think, a game changer in terms of what we learn and how we do things. What I will also say is that currently the system is like this, right? Like, who knows? We don't, nobody can even describe like where to go, obviously, when there is a problem. And so we tend to take shortcuts. The more resources you have, the easier it is to take a shortcut, which then reinforces all the disparities that we're trying to eliminate. And so part of what the effort collaboratively would be is organizational and conceptual and mapping that out. And so when I talk about the opaque and bewildering triage, I'm thinking about experiences that I've had, for example, in refugee camps, where I came in with my mindset of I'm under-resourced, but I had no idea what really being under-resourced was, right? So being really under-resourced means there was not a single psychiatrist available for 1 million refugees when I wasn't there, for example. And so part of what systems that are very under-resourced and have urgent, important crises do that we need to do in mental health is this sort of triage pyramids, you know. So here are two examples. One of them is what you do in refugee camps, where you have interagencies, in a sense, making sure that basic needs are met. This is like a trauma response pyramid, if you will. Like, are people eating and drinking and hydrated, and do they have a place to sleep? And then you're looking at, can people support them? And then you're looking at, do they need more focused interventions? And then at the very top, you have interventions. So I'm not saying we're going to have something that severe, because we're actually more resourced than that, but we do have some kind of pyramid where we sort of say, actually, you're really worried about this kid, but maybe we need to keep them at the bottom of the pyramid. And then I'm not even talking about the effort that a lot of people are doing at UCSF and elsewhere on infant mental health and relational mental health, and how critical that is to change the shape of that pyramid as well. So that is something that the collaborative care clinic that we've started, and that includes Sabrina Fernandez, one of the pediatricians, to work with us very closely on understanding better what facilitates an easy referral and what makes it difficult, you know. And so we're identifying factors that we really should have thought about long ago, you know. So this could be parental factors, but if we have limited resources, we need to do that. So do I have the luxury to sit for 10 sessions convincing a family with motivational interviewing about psychiatric approaches? That's what I learned to do. I don't know if it's a good stewardship of my skills. It's great that I can do that, but I think there are empirical questions about, can I do it faster? Can I also do it in a way that maybe parks the family for a while, which, by the way, empirically would be fine, and sort of not fall into the trap of letting that block the flow of traffic. And on my end, sort of looking at what I call Hotel California and other outdated practice habits, what I'm learning. So first of all, I knew about Hotel California. What do I mean by that? I mean this idea that psychiatry developed as a field in a sense that was really based on psychodynamic conventions. And so the psychodynamic conventions is you have a patient that's on a couch for years and you let them get better very, very slowly. So first, this is an intervention that is completely not adequate for most people, definitely not adequate for every population, and also very, very, very laborious. Like it's not practical with the epidemic that we have. So we've moved from that, but we still have practice habits that involve kind of open-ended, come on here, and now I'm your doctor, and I'm going to be your doctor forever. And it's compounded by the fact that there is such a backlog, and that when people arrive to us, they are hanging on for dear life. And so what I can tell you is that my team hasn't developed the immediately deployable skills of having conversations about that uncomfortable situation. And so what I'm observing in the collaborative care clinic is patients turning to my fellows or to my young attendings and saying things like, you're going to be taking care of me now, right? And that I can see that my team is not confident about sort of the boundaries that are needed to really reorient people to the reality of things and do it in a compassionate way. So educational issues are definitely also a problem for child psychiatry. And this is actually something I've written about before, you know, to just highlight that, again, I'm not new to thinking about this. So the idea that we need to rally has existed for a very long time based on very scary epidemiological data. And in this commentary, I definitely put the accountability on both specialties to create a space where we can do this together, but also to not have child mental health just continue doing the things that we do that do not incorporate this reality. So I'm going to stop soon to allow for some questions. But one of the things that I want to do is show you some of the faces of the people who are already in this space and that I'm already talking to. And so Meg, you see yourself, we've only had 1 or 2 conversations, but clearly our relationship is going to be really, really vital in this enterprise, because I don't know you well, but I imagine that you're also connected to a lot of people that we need to bring in to this conversation. I would like residents involved in this conversation, because one of the things that is going to be uncomfortable, and actually Lee, who is also here, has creative ideas about that, is how do you deal with a disruption that empowers the trainees and the younger people with skills that their role models don't necessarily have? That's a complicated thing. And, you know, there are multiple things we can do. One of them is debrief about that, but we could also think about ways to making sure that every pediatrician who wants to has the opportunity to develop these skills. I want to have clinical spaces that maybe make that possible, where we're together collaboratively taking care of patients, and you can retool basically and organize better what your child mental health skills are. So I'm not going to cite everybody in this group, but these are all people who are currently really vested and interested in collaborative care. I have some new faculty like Josiah, Cox, who is at Oakland and who is actually a pediatrician. So people who are pediatricians and child psychiatrists are particularly important in our group because they can bridge. And so we have him. We also have Jean Yoon, who's also at Oakland. You all probably know Petra from her work at UCSF for many years and also for her leadership of the CAP portal. And there are people that I'm just meeting that are technically on my team, like Kate Margolis, who is the head of the integrative division, in psychiatry at the ZSFG. I also want to shout out to this woman. So Jan Jager, he's a part of the Care Wisely team that is helping us with the collaborative care clinic. We got funded to have their help, and she helped me with the graphics, the graphics that you saw of the web of causation was much more ugly before she got involved. And she said I didn't need to give her credit, but what kind of person would I be if I didn't? And many other people. So anyway, I am going to stop there and ask for questions, either on Zoom or in the room. And I really thank you again for this invitation. And I hope that I accomplished the goal of conveying emotion and willingness to partner together. Thank you. Go ahead.
I have a couple of questions. First of all, thank you for this great talk, and I'm really sorry about your cat.
Thank you.
I lost my dog not too long ago, and it was actually very interesting. I tore my ACL a few years ago, and I got a lot of sympathy, and losing my dog was not so present. It was much worse for me than tearing my ACL.
Exactly. That's why I mentioned it, because it's a mental thing. It's a grief thing. And so we tend to just not share. And when we don't share, the environment is not as safe for us. And people can tell we're disconnected, but they're not sure why. Yeah, thank you.
The question about safety, actually going back to your comments around like us, right? Well, we as physicians share, don't share around mental health illness. If I remember correctly, the American Medical Association actually at some point put out a statement around disclosing mental health issues for physicians and licensing organizations. But despite that, most licensing organizations, I think, definitely the California board, still ask about physicians to disclose mental health, perhaps only if they impair daily practice. But I was a program director for many, many years. I never had to tell the medical board if I had a trainee who went through, let's say, cancer treatment and was in remission but could relapse. But I did have to tell if I had a trainee who was dealing with, for example, alcohol use disorder and was in remission. And in some cases, the California board relentlessly pursued that issue, even if someone had been completely sober for like 5-6 years and said, nope, no more license in the board of the state of California. So I think this fear of not disclosing mental health issues is
no, so you're definitely, I think you're talking about something real that is often cited by people who are suffering from mental health issues. And I would say that the way I think about it is, first of all, there are people who are working on that way too slow, but clearly this needs to change. But that also, this doesn't explain why we don't talk to our children or our spouses or our colleagues or our bosses about these issues. And it doesn't explain the shame that we have, because this would be equivalent to being, I'm exaggerating, but coming out with your mental health issues and having sort of the discharge of the shame that you carry is a very important experience. And it's akin to coming out of a closet. You know, like people talk about stigmatization for mental illness. It is like being minoritized. So there's definitely the same dynamic of I'm ashamed. People see this as shameful. I've internalized that, and it's very hard to really understand how this is impacting you until you start coming out of the closet and you're like, holy shit, this is what I was carrying. And so there's a little bit an analogy here that you don't stay in the closet just because the environment, like this is happening in this country right now, right? People are being told to be in the closet for various things. And I think that what we're seeing is that it doesn't alleviate the tension, that it is healthy to come out of the closet. And I think certainly to your point, what I did as a training director is that I was very concrete about, is this impacting the performance now? And that's sort of where I drew that line. You know, so somebody actively drinking, first of all, they probably wouldn't be graduating because this is like intra-professionalism issue. But I think that we need to, you're right, we need to be practical in a system that pushes for fear and exacerbates the stigma. For sure. Thank you so much, Sandrine. Other comments or questions? So
I have one more, if I may.
Sure. Nobody's asking anything. Okay. I'm not going to take it personally, but
I guess it might just highlight how difficult of a topic this is for people.
That is true.
The other thing I was going to ask you, and I don't know if you know this question because we compared notes, and I know that you've been as long in the away from France as I have been away from the Netherlands, but I've been always astonished how little this country, at a political level, at a national level, invests in the well-being of their children and in mental health care, especially very, very different from what the Netherlands looked like when I still lived there. And I use that disclaimer because I don't know if things have changed. Do you have international comparative data?
I do. So it's not super updated, but there was a paper mid 2000s, maybe 2006 or 7, that looked at the very simple empirical question that you're raising of, at a national level, one, is there a mental health plan? Like, is there a health plan that's outlined by the government that addresses mental health? And then the second question was, does it address specifically mental health for children? And then the other question was, is there a separate mental health plan for children? And so what I can tell you is that, so this is now 17 years ago when this was looked at, the countries that had a specific mental health plan for children were a very, very tiny minority, like 8%. And that maybe 18-20% of countries then had like a mental health plan that mentioned children. But so a mental health plan as part of sort of governmental vision and strategy is probably still uncommon. And then when it comes to children and adolescents, extremely uncommon. And you're right, there are islands of exceptions like the Netherlands or Scandinavian countries that, you know, initiated things like ombuds for children in difficult situations. So there are definitely countries that are more advanced on the concept that mental health or health is a human right and that it requires a strategy. But thank you. And in this country, we have, one of the reasons that we have to do things at a grassroots local level is because there is no central plan. But I think in California, especially with the CAP portal, especially with more money being poured towards child mental health initiative, especially with the mandate to train pediatricians, and especially if we really do the hard work of addressing our own biases, I think we have a moment of opportunity that is actually very different than in other states.
Well, that is an optimistic end and a nice counterpart to a comment from the chat that says
The presentation was truly outstanding. We have so much work to do. I think the silence might reflect how overwhelming the task seems to be in this country.
It is overwhelming, but that is why mapping it out can allow us to sort of be confident that even if we're not seeing a result immediately, we're addressing a very important component in what is indeed a very complex causation chain, if you will. So I think, like, the way I think about it as an academic is that, first of all, it's something we have to do because of our calling, but that also there are silver lining aspects that, for example, young people can develop careers that are related to this effort. It's definitely a low-hanging fruit. And that's some of the things we're going to do. So I'm talking to technological companies to look at the problem of triage, because clearly it's going to exceed the mathematics that I can do. And AI, as you know, is actually pretty promising in some domains, including that. So I think that we are going to have an opportunity to try things, and that in addition to doing good, if we needed another incentive, I think this would be interesting, intellectually stimulating, and potentially fruitful for people too.
Fast one.
Okay.
One more question here that maybe we can actually address, and you can share with us so that we can share it by email. With
Sure.
It's about an online resource for family practitioners to actually find resources for patients with mental health issues.
The CAP portal. So basically, the CAP portal, you know, that I alluded to is actually incredibly organized in that respect. I don't know how to open the link, but if you go to, just put CAP portal UCSF and it takes you right there.
I will ask Laiba to include that in the email
Thank
that
you.
we send out to everybody.
Thank you.
Thank you so much for joining us today.
Thank you, Sandrine.